Your presentation, you can see it from your system.
Okay.
And we will upload it at a later stage. Along with YouTube updation, we will do it along with that.
Okay. So you want me to open my presentation?
Yeah. You can go through with your presentation. The presentation will be available for the viewers after 1 hour or 2 hours. We will do that technically and we will get it done.
So he's not sharing it like he did it earlier at your end?
Yeah, we will do it at our end.
Now, or I should
Later.
open it in
You
later?
please open it in your system.
Okay, so I have opened it in my system now.
Yeah, you can go through with your presentation. Yeah.
All right. So
what we'll do, I'll just have a formal introduction. Then it will be over to you.
Okay. Okay. So what I can do is I have minimized it. You can do your introduction bit, and I'll get back to it.
Sure.
Okay. Yeah.
Very good afternoon to everyone. Today we are on the fourth day of fourth webinar series from Gandhigam Rural Institute, deemed to be University, Tamil Nadu. We are coming up with different subjects with very eminent speakers, and within a very short time, this webinar series has reached international level, and I am very thankful to all our alumni, those who are in abroad, and friends. At the outset, let me thank our Chancellor, Dr. K.M. Annamlai, for giving me this opportunity, along with our Vice Chancellor in Charge, Dr. B. Subraj, and the Registrar, Dr. V.P.R. Sivakumar, for supporting us in successfully conducting this webinar series. We have today very eminent speaker, very renowned academician and a nutrition, a specialist, you can say, an authority in her subject, rather, I should put it in this way. Professor Deeksha Kapur is with us. Professor Deeksha Kapur is, I'll just give a formal introduction about Deeksha ji, and then over to you, ma'am. Dr. Deeksha Kapur has done her PhD in nutrition from University of Delhi, MSc in food and nutrition, Lady Irwin College, University of Delhi, and BSc Home Science honors from Lady Irwin College. Then postgraduate diploma in distance education, PGDE from IGNOU, New Delhi. She has a diploma in sports nutrition, International Olympic Committee also. Professor Deeksha Kapur is an eminent nutritionist, professor in the discipline of nutritional sciences in School of Continuous Education, Indira Gandhi National Open University, New Delhi. She has distinction of setting up the discipline of nutritional sciences at IGNOU. Something that you have created it, Professor. The credit goes to you. I'm really happy and amazed me. She is engaged in adjunct professor in Welcome Group Graduate School of Hotel Administration, Department of Allied Hospitality Sciences, and Department of Culinary Arts, Manipal Academy in Mahe in Karnataka. Professor Kapur has contributed extensively in designing, developing, and implementing niche programs geared towards capacity building, vocational skill, and professional development of individuals in the area of nutrition and dietetics. She specializes in development of self-learning material and use of multimedia and e-learning resources in teaching, learning of nutrition. Professor Deeksha Kapur is the program coordinator for PhD Food and Nutrition. A lot of students have got guided under supervision. Postgraduate certificate, diploma in pediatric nutrition, diploma in nutrition and health education, certificate program in food and nutrition, certificate program in nutrition and child care, and certificate program in safety at Indira Gandhi Open University. Professor Deeksha Kapur has provided technical and resource support to the national and non-governmental institutions for curriculum design and development, research activities, and dietetics. She is a certified trainer and evaluator of food safety and standard authority of India, FSSAI, and has many training programs to her credit. Professor Deeksha Kapur has extensive research experience and has been awarded the research projects funded by UNICEF, Department of Science and Technology, Ministry of Health and Family Welfare, Government of India, Distance Education Council, She is a recognized PhD guide. Her research interests include maternal and child nutrition, public health and nutrition and non-communicable diseases, clinical nutrition, sports nutrition, food safety and quality control, institutional food administration. Prof. Deeksha Kapur has presented papers in numerous national and international conferences and has several publications in peer-reviewed journals to her credit. She has authored chapters for recently introduced nutrition and dietetics course at a senior secondary level for CBSE. She is also an advisory and editorial board of international journals. Professor Deeksha Kapur has a membership of national level committees and statutory bodies at IGNOU and other universities. Today, we have this distinguished guest to give a lecture on role and importance of nutrition and its awareness among rural mothers and children in building new India. Welcome to you, Professor. We are blessed to have you in this webinar.
Thank you. Thank you so very much, Dr. Krishna Kumar. I think I need to thank your Chancellor, Vice Chancellor, your Registrar, and to you in particular to invite me today to make this presentation. Yes, nutrition is very dear to me, and I have been working in this area for the last 35 years now. And even the topic which you have taken, or rather you have given me to speak of, it's very unique. And my presentation, I will try to focus primarily on the rural children, women, and give them a perspective of where we stand today when we talk of nutrition. So thank you once again for inviting me. So participants, the faculty at
And
your
students.
institute, and students. Uh, well, I am grateful to be here, honored to be here, to be able to give this talk in such a famous and a known institute. So let me start then without wasting any more time. Let me so I'm going to be talking about the role and importance, as I've already said. Dr. Krishna Kumar has already highlighted role and importance of nutrition and its awareness among rural mothers and children in building a new India. Well, we certainly need people, we need change agents to bring about a change when we talk of nutrition. Well, the importance of food and nutrition, I don't need to emphasize, but just to tell you that even the Bhagavad Gita, the third discourse there, talked about food. I will just read the initial verse which talked about Anad Bhavanti Bhutani, which practically translated to from food creatures become, implying that what we eat, we become. And this importance, food is the first among many basic human needs. There is no denying this fact. It is a basic need. And understanding this, the
Creatures
UN
become,
Committee,
implying
UN,
that what we eat, we become. And this importance.
sorry,
Yeah, sorry, sir.
okay. Should I continue?
Yeah, please.
Okay, so the UN Committee on Economic, Social, Cultural Rights states that the human right to food, it is recognized as in several instruments under the international law, that the human right to food, especially the Article 11 of the International Covenant on Economic, Social, Cultural Right, it recognizes the fundamental right to freedom from hunger and undernutrition. Hunger leads to hunger, basically meaning lack of food, which the nutrition outcome is undernutrition. So, the fundamental right to freedom from this has been articulated in Article level. Now, Even more lately, we have the Sustainable Development Goals. These SDGs, so-called SDGs, was adopted by the United Nations member states in 2015 as a universal call to end poverty. There were 17 goals which have been laid down uh, in the Sustainable Development Goals, out of which, as a nutritionist, or the goals which concern us are primarily four. I have highlighted three here. The first, second, third goal. The first talks about no poverty, eradicating poverty in all its forms. It remains one of the greatest challenge facing humanity because poverty leads to low purchasing power, which leads to lack of food. The goal, second, which talks about zero hunger, extreme hunger, and malnutrition. It remains a huge barrier to development of mankind today. Food insecurity appears to be increasing not only in the developing country but all over the world. So, zero hunger is the second goal which the SDGs talk about. And the third goal is on good health and well being. Well, we all know what we eat, we become. So the nutrition, your nutritional status is directly linked to your health and well-being. So good health is essential for development. Of course, another goal deals with safe water and sanitation, which is also linked to leading a healthy lifestyle. Now, in this sustainable development goal, we've talked about food insecurity. That insecurity is increasing almost in all regions. It is important to understand what we mean by food insecurity. Well, to understand this, let us look at the definition of food security first. The World Food Summit presents a very simple definition. It talks about food security at the individual level, household level, national level, regional level, going up to the global level. And it says this food security is achieved when all people at all times have physical and economical access to sufficient, safe, and nutritious food. It doesn't stop by saying access to food, it says access to sufficient, safe, and nutritious food. What for? To meet the nutrient needs of each and every individual, not only the needs and also cater to food preferences for an active life. So, understanding this definition, what we must understand that food security is just not about providing food, but being able to provide all the nutrients which are needed for a healthy life. Therefore, food security is different from nutrition security. Very usually or generally, when we talk about food security, we tend to miss out on the nutrition security, which is physical, economic, environmental, and social access to wholesome food, to a balanced diet, to nutritious food, and clean drinking water for every child, man, women. Why? So as to meet their nutrient needs. We may have access to food, but is it of the right quality? We need to understand the difference. Basically, what we are talking about today, that diet quality is a critical link between food security and the nutrition outcome. That is, what quality of diet individuals are consuming, that will influence food security and the outcome, what happens. So I have tried to conceptualize food security for you in this flow chart, what you see. So, food intake, food security is about access to food. Now, this access is just not access in terms of income, prices, purchasing power, access to market, but also available. There should be food available for individuals wherever they live. It is also in terms of use. We have the food, but if we are not aware, if nutrition knowledge, nutrition education is missing, the behavior, the nutrition behavior, what we call as behavior change, our attitudes towards certain kind of food is not changed, then the using food security in terms of use is hindered. And of course, the utilization is also an important factor. And as you can see, all these factors are influenced by socio-economic conditions, environmental conditions, the population growth. So, the food security overall encompasses food intake and these components which influence your food intake and indirectly the nutritional status, health status of the individual. So, once we have understood this concept of food security, what is important? What I talked about, that what is the diet quality that will influence the nutrition outcome. So, before I go on to this, I think it's time we understood how food and nutrition secure we are as Indians, and particularly the vulnerable sections, the women, the children, and that too, the rural population, how secure we are in terms of food and nutrition security. So, well, it is very unfortunate that the food and nutrition insecurity in India is very large. It is huge. How do we know? How do we measure? Well, there are various range of estimates which are based on different data sources. There are multiple indicators of food and nutrition which are available, and some I have listed for you. Food intake measures, when we analyze the food intake of population groups, we get an idea how much the people are getting, what is the deficiency in their intake based on the recommendations. So, food intake measures give us a good idea. Then, the expenditure indicator, how much of our income we are spending on food. What is the purchasing power of the people? Is it sufficient to meet their needs? This kind of data helps us to find out, are we secure in terms of food and nutrition? And I said ultimately it is the nutrition outcome. What happens when we do not get adequate food? We've talked about malnutrition, undernutrition. How do we measure it? The most simple way is anthropometric outcomes. Measuring weight, height, and other measures give us a good indication whether we are on the right track or not. So, these are the measures which help us to measure food security. Now, what do the data says? I have been able to put forth to you the latest data which I could lay my hand on. There is a report on the state of food security and nutrition in the world. Each year, this report is prepared by the Food Agriculture Organization, UN, and the last year report confirmed that no country comes close to India in terms of the sheer number of people who live in chronic numbers. And they have estimated there are about 822 million undernourished persons in the world. And ironically, 24% of these people live in India. So that is the scale of food insecurity we are talking about. And what is more alarming is today, when we sit in COVID times, since 24th March, we all know we are under lockdown. And this has resulted in the collapse of employment. We have seen it. Large number of workers, basically from the informal sector, the agricultural laborers, the construction site workers, people who are working on their own, with no social security, no job security, we see that the incomes employment has collapsed. And this means no income, no purchasing power, and inevitably this will affect the food security. So we already have data which shows that India fares so poorly, and what it is going to be, it is sad to see. So as we have already been talking about, that the diet quality is critical to food security and to nutrition outcomes. So the latest 2020 report of state of the food security and nutrition in the world, what they have done, they have tried to classify diets or diet quality to give an idea that what should be a good diet. So they have been able to identify three basic diet qualities. The first, they talk about a basic energy sufficient diet, meaning a diet consumed by people where their basic need for calories, say for a 30-year-old woman, globally, if the uh, norm for energy, say, is about 2,300 calories, then to meet this requirement, this is met by the cheapest source, which is the cereal, which is the staple food for most of the population. So this they classify is as a basic energy sufficient diet, only meeting the energy requirement. The second category they talk about is a nutrient adequate diet, where the calories are met. In addition, requirement for macronutrient and micronutrients can be met. So, in addition to cereals, maybe some amount of pulse, maybe some milk, maybe some seasonal vegetables may be included in this nutrient adequate diet. But it is the third category which they classify as healthy diet, perhaps a balanced diet which meets the requirement of the previous diet, which I talked about. How? By including items from a diverse food source. Therefore, including food from different food groups so as to meet the requirements for most nutrients, just not a little. So, a healthy diet. This is the kind of a diet quality this report talks about. Now, what is important is to see where do we stand in this category. But before we go on to analyze whether the diet quality and how food secure or insecure we are, there is another concept I want to tell you, that is about affordability of a diet. Now, we have looked at the three different diets. Which diet is affordable? What the report states, that cost of a healthy diet is about 60 times higher than the cost of a nutrient adequate diet, and almost 5 times the cost of a energy sufficient diet. So from this we can ourselves make out that a person with low purchasing power, belonging to an underprivileged, disadvantaged section, for them to be able to afford a minimum healthy diet becomes a big question mark, and we need to consider this. Now, with this backdrop, let us now understand what is the food and dietary intake nutritional status of women and children, particularly I am going to touch on the rural data for India. So, how food secure or insecure we are. I have tried to give you the national data, whatever is available till date. I have tried to put in my slides. So, going to give you the time trends. I am trying to cover the last 4 decades, starting from 70s till now. Let us get an idea. So here is the first slide, which gives us the time trends in the intake of foodstuffs for children 1 to 3 years of age. And what we are presenting is in terms of percent recommended allowances. How much the diet, the food people are eating tend to meet the recommendation. And as you can see, for each, on the left are the food groups, and I am covering the last 4 decades, starting from 1975 till 2012. And this data is from NNMB, the National Nutrition Monitoring Bureau, the agency which was tasked with analyzing how food secure the population is. Are they meeting their needs in terms of recommendations? And what do you see in this slide? Mind you, we are talking about young children from rural background, children 1 to 3 years of age, the most critical period of life, one of the most critical periods of life. What do you see? Look at the cereal intake. We talked about the energy sufficient diet earlier, and we said they are only providing cereals. But look at the population. Over the last 4 decades, the need, the requirement, what is the trend? There is an decline in the average intake of cereals and sugar and jaggery in the diet of these children. Pulses, milk and milk products, fats and oils may be slight increases but not substantial. Similar pattern if you look for 4 to 6 year old children. Even their intake, the average intake of cereals, of millets, sugar is declining over the last decades. Yes, in between the 80s and 90s, there was substantial improvement. But in the 20s, what you notice, if you look at it, the cereal intake. Again, the sugar jaggery, these are the foods which give energy. They have declined, but there is an increase in the fat intake. Okay, mind you, keep this in mind. We will link it later to our presentation. So the fat intake is increasing, but cereals are decreasing.
Can you just,
Similar pattern.
sorry
Yes,
for cutting, Professor. Can you
yes.
just try and put it this slides also? You can try if it is coming.
Uh, you mean should I go back and start again?
No, no, no. Just on your flow, try and from now onwards.
Yes.
Can you
What should I
just
do?
try and get it in presentation also, if possible?
You
Just
okay? Okay. You will have to then give me 2 minutes to get back because now I've opened it, the slide sharing
okay,
on my laptop. So
okay.
I have to stop and then go to share and start again. Is that okay? If you give me a minute.
Yeah, 2 minutes, please, please.
Okay, all right. So I will give me a second. I will get back and try from the site again if I can log in.
Yeah,
Just bear with me. Okay, so here I am. Let me try again. Okay, so you can see me.
yeah.
Okay, so I'm present now. Okay, I am getting there. Hopefully, this time it should open up. It will be great. I'm afraid no,
It's not,
it's it's not sharing. It's not sharing. It just says you are presenting to everyone.
but it's not visible. Anyway, we will continue
It's
with
not
this
visible.
like
All
this.
right. All
We will
right.
do it
So
later.
Should I stop share and get
Yeah,
back to my
yeah,
visuals?
yeah, please,
Okay,
please.
okay, okay. All right. So I was talking about. Give me a second now. Okay, from beginning. Okay. So I was on the slide where I was showing about the intake, the time trends in the intake of food groups by women, basically 18 years and older. And as you can see, the average intake of cereals, millets, the first bars, what you see, sugar, nuts, oilseeds, all are declining from the period 1996 to 2012. But look at the fats and oils, there is a increase in the intake which has been shown. Again, make a note of it, and we will link this later when we talk about nutrition outcome. So this was about food intake, food security. Are the foods enough to meet the food security norms? Now, translating the food in terms of nutrients, because cereals will give us energy, pulses will give us protein. Let us translate that in terms of nutrient intake, nutrition security. What are the trends which we are seeing? The trends in nutrient intake among, again, 1 to 3 year old rural children. And we are presenting it again as percent of the recommendations. We all know these recommendations given by the ICMR, Indian Council of Medical Research, which works out the recommendations for Indian population. Now, what do the food intake data show? It shows that the energy intake barely meets 72% of the recommendations for children 1 to 3 years. What is even sad that the intake of calcium, iron, the micronutrients. If we were even to talk about a nutrient rich diet, even that calcium, iron, for iron, only 64%. Calcium, 40% of the RDA is being met by a diet of a 1 to 3 year old child. Now, such kind of poor diets, which are reflecting in poor nutrient intake, certainly reflects in undernourishment, in poor nutritional status of young children, under 3 children in our country. When you look at the statistics of the nutritional status, you will see direct relation between their nutritional status and what they are eating. Similar trend is seen for 4 to 6 year old children. The average daily intake of energy, calcium, iron, which are basic nutritious diet, healthy diet, their requirement has been declining over the last 4 decades. The intake of vitamin A, niacin has increased, but even those do not meet the recommendation which have been provided by ICMR. So we are again talking about very poor nutrient intake, nutritional status of young children. So we have seen a whole generation of young children, 1 to 6 years, for the past 2 decades, 3 decades, is surviving on a poor diet, poor nutritional status. Similar trends, if you look for adult women in our countries. I'm taking example of sedentary adult women more than 18 years of age till 49 years of age. Look at their requirement. Average daily intake of all nutrients except perhaps thiamine or niacin, they have declined over the last 2 decades. Starting from 1996, the data shows a declining trend for most nutrients in the diet of these women. So What are we looking at? We are looking at a very poor food, a picture where food insecurity, nutrients insecurity is rampant. That is why the report of the state of food security, nutrition security clearly puts India that there is a real problem with regards to food security. Look at the energy intakes. Here I am giving energy intakes for normal, uh, 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 non pregnant, non lactating women more than 18 years, and pregnant women, and the green bars are for lactating women. What is the picture we notice? The dietary intake in each of the three categories is below RDA. The recommended dietary allowances, even these women are not meeting those recommendations. Well, there is some improvement in the energy intake in the 1960s, as you can see from the second block here. There is some improvement, but subsequently there is a decline. There can be many reasons. The physical activities maybe have come down. So when they have come down, so the expenditure is also low. There can be many reasons. If you go into the factors, we can come up with finding the factors. But there is no increase in the nutrient dietary intake during pregnancy and lactation, which is such a sad state of affairs. Pregnancy and lactation are considered the most critical physiological periods of life. They are critical because that is the time when the mother supports during pregnancy growth of the fetus, and during lactation the growth of the living infant. And in those conditions, if the maternal diet is inadequate, insufficient, the mother is malnourished, we can very well estimate what is going to be the outcome. And the outcome I will share with you. I will give you the statistics. What is the statistics for our country? So there is no increase. Whereas during this period, the mother needs to have additional calories. For example, if a mother needs, say, 1900 calories, a sedentary woman may require about 1900 calories. She needs an additional 350 calories during pregnancy. Lactating women may need 1900 plus 550 or 600 calories as the lactation progresses. But what do we see? There is no change. What she was eating when she was non pregnant, non lactating, perhaps she is consuming the same diet. So, how is the fetus growing? What is the impact on the child? It will be very obvious when you look at the data, which I'm going to present now. So, similarly, you see, I am taking you through the life cycle. I started with a child, first year of life or 1 to 3 years of life. What is the nutritional status in terms of food and nutrient intake? We talked about women. Look at the infant and young child feeding practices. That is the first year of life. That is the most critical period because maximum growth and development takes place during that first year of life. And what do we see? Based on the National Family Health Surveys, these are the surveys which are being carried out for the last 4 decades. So we have data for NFHS4, which was in 2015 and 16. Before that, it was 10 years back, and we are already going to have an NFHS data 5, which will be coming subsequently because the work has already started. But what is the situation here? If you look at, there is an improvement in the early initiation of breastfeeding. What do the recommendations says? The guidelines for young child feeding practices clearly state that the child should be put on the breast within an hour of childbirth. Now, what do we see? Today, about 41.6% children are put to breast. As compared to the last data, what we saw, only 23%, one fourth of the mothers were putting the child to breast just a decade back. There is an improvement, but not even 50 women are still putting the child on the breast as soon as the child is born. What about receiving the complementary food? That is, when the child is introduced to solid food at 6 months of age, other than breast milk. So, the data for children aged 6 to 8 months receiving any semi solid food and breast milk, what do we notice? In last decade, it was 52.6%. And today, in 2015-16 data, we notice even that number has come down. And what did we see? That a mother who is undernourished, you will see, will give birth to a child who is undernourished. Now, this child, when this child is growing, the first 6 months, breast milk is sufficient to meet the needs. But at 6 months and thereon, we need to start the child with other food, top food, complementary food, whereas not even 42% mothers are putting the child onto complementary foods. What is going to be the outcome? We will see. Similarly, so what we have, the picture which is clear to us that infant and young child feeding practices overall have remained suboptimal till date. They are suboptimal. And how does that impact this nutrition? How does it impact? What is the nutrition outcome? The health impact, which is associated with this diet quality, a poor diet quality. Let us now take you through this set. We have seen food insecurity, nutrition insecurity, just not for one period, last 4 decades the population is being deprived, is not meeting. What is the nutrition problem? What are the public health problems facing the country today? Well, multiple burden of malnutrition. We talked about dual burden few maybe a decade back. We did earlier we only talked about undernutrition. Then we started talking about dual burden. But today there are multiple burdens of malnutrition. What are these multiple burdens? Undernutrition, as I said. Undernutrition, lack of food, lack of protein, energy, leading to three basic forms of malnutrition, rather undernutrition, which is underweight, stunting, and wasting. So, I am talking about the burden of malnutrition. What is malnutrition? Malnutrition, if you want to define it, it is the condition of the health as influenced by lack of intake, excess intake, or imbalance in your diet. Any of these three, the condition of health is called malnutrition. So earlier, malnutrition was only linked with undernutrition, lack of diet. No, it is just not lack of diet. It is excess of diet. It is imbalance in the diet leading to malnutrition and multiple burdens of malnutrition. The first level is your undernutrition reflected as low height for age. meaning the child is born stunted, or as he grows, he is stunted for his age. This is called stunting. Underweight, the child is of low weight as compared to the standards, or wasted, where the weight is low for that height. So these are the three indicators, and they give us an indication of the subclinical forms of malnutrition, undernutrition in a community. So all we have to do is to measure height, weight, and we get to know whether the child is stunted, underweight, or wasted. So, undernutrition is rampant. Micronutrient deficiency. We've talked about the diet not being healthy, not being balanced. Micronutrients like iron, like calcium, and other today zinc, iodine, they are lacking in our diets, and these deficiencies are leading to major public health problems in our country. Iron deficiency, anemia, vitamin A deficiency. We are talking about iodine deficiency disorders, and adding to it today, zinc deficiency is also becoming a major problem in our communities. So, this is one level. The other is low birth weight children. Children born to such mothers who are undernourished, they give birth to low birth weight. What is a low birth weight? Any child who is born less than 2,500, as the NFHS 4 data, which is the last data we have for reference. What you notice, look at the trends. The trends certainly is a good thing. In 70s, when almost three-fourths of the children under 5 years of age, preschool children under 6 years of age, we saw were malnourished or undernourished. Their weights were low, their heights were low. Not only the heights and weights, but also they were wasted. From 75, 82%, we have at least come down to 36, 38% of stunting and about 20.6% wasted. But is it any, uh, does this data tell a good picture? Even today, if one third of our children are underweight, are stunted, what is the quality of life? How is it going to influence not only their productivity but also their scholastic development, mental development, emotional development? We can, this data shows. What is most alarming? Look at the green bars. From the last 2 decades, we would have thought that today, with the government putting so much of interventions, inputs going towards child health, the wasting levels, that means children whose weight are low for their height. It has increased from 90s to about 20, almost the same. And in the last decade, from 15, it has risen up again to 20.6. Now, this picture gives a very poor situation for India. Yes, we have improved over the last 4 decades, but one third of the children, if they are not uh, well nourished, we need to think. We really need to think. Look at, I am now only presenting the National Family Health Survey data and not very far off, just the last decade and the present 2015-16 data. You have got an idea. Yes, here in this slide, I am only presenting wasting, underweight, stunting, and severe wasting, stunting, and underweight. What do you notice? Again, children who are wasted, those numbers from the last a decade back, there was only 9. Look at this one right in the center, the red circle. There were 19.8% children who were wasted. That level has come up to 21. And what about the severely wasted? You see, there is a classification where we look at severely wasted, severely stunted as those less than -3 standard deviation of the mean. And what do you see? 7.4% children are still wasted. This is the data for children under the age of 5. Yes, there has been improvement in the last from the last decade to today in the stunting rates and underweight. But as I've already mentioned, it is still very high. We can't be proud of our nation if 35% children are still underweight and 38% children are stunted. The repercussions, the outcomes I've only talked about a minute back. But there is hope. You know, in 2016-18, a comprehensive national nutrition survey was undertaken. Data from states was collected for all children from birth to 19 years. Yes, there has been visible improvement from NFHS 4 data, the stunting levels have come down, but very slow from 38.4 now in 2018. They are only showing a marginal reduction to 34 or 35%. Similarly, wasting of 21% has come down to about 17%, and underweight from 36% to about 33%. So we have hope, we are improving, but not at a rate which our country needs. So we have the good picture also emerging. We must be happy, but we must work harder to reach the targets. What are the targets? I will talk towards the end of my presentation. Now, the trend in early childhood mortality. So far, I talked about morbidity. Morbidity is children being undernourished in terms of stunting, wasting, children who have the disease condition. Mortality is death. What is the mortality rate? If you look at the infant mortality, child mortality, infant mortality is for children under 1 year of age. Child mortality, we have covered till 3, and under 5 mortality, which is the last gray bar, which is for all children under 5 years of age. Of course, there has been a gradual decrease in childhood mortality rates in our country. Starting in NFHS 1, we had almost 100% children, or 109, as you can see, NFHS 1 data showing such high rates. They have come down to a prevalence of only 49.7 today. But even still, it is very, very high. We need to understand, we need to change this equation. It is basically the under 5 children which are at risk, and we must understand there is a significant drop, but we need to do more. Look at adolescent. This really pains me when you look at adolescent like infancy, the first year of life. That is a rapid growth period. The next rapid growth period is the last and the adolescent stage. It is a critical period because if the child misses out on growth in this last period, which is the rapid growth period, the child is for life going to be undernourished. So look at the prevalence of stunting. What does stunting indicate? Undernourishment, but long term deprivation of food, chronic undernutrition. Weight can be influenced by small changes in day to day food intake, seasonal changes, but The height gets affected when the child is deprived of food for a very long period of time. That is why it reflects chronic undernutrition. And what is the data? In a decade back, the stunting among adolescents, that is age 15 to 19 years, was only 29.1, with more girls found to be stunted. You know, on your figure in the left, you see the yellow bars, and then you see a dark blue and the light blue bar. The dark blue is for India, the pooled data, and on the left is for NFHS3 data. On the right is the 2015-16 data, NFHS4. What do you see for India? 29.1% children were stunted a decade back. We would have thought over the years these figures should have improved. No, rather they have gone up to about 34.1%. And in both the cases, it is the girls, the adolescent girl, who is most affected. This girl who is going to be the future mother. This is the state of her health. High incidence in rural areas. If you look at the rural area, which is the light uh, blue bar, for the national, if it is 34, in rural areas, 36% of our children are stunted, reflecting chronic undernutrition over a very long period of time. And the different bars I have tried to give you for different states. Majority of them are under the national, but there are these 10 to 11 states where the stunting is as high as 64, 62%, like Meghalaya, Arunachal Pradesh, Bihar 44. So all the bars on the top you see, they are the worst affected. The girls, adolescent girls are worst affected. We need to consider. Look at this. Now we have talked about dual burden of malnutrition. We have not been able to overcome undernutrition, stunting, wasting, underweight, or now we have to grapple with overnutrition. Look at this data again from National Family Health Survey. I have tried to break up in terms of age of women. From the top is for wasting or thinness, and the bottom bars is for overweight. What is the trend which you can notice? Undernutrition levels are higher among young girls and women. As you can see, NFHS 3, 4 data both have given higher figures. Yes, there is a little improvement in 2015-16, but till 20 to 29 years of age, if you notice, one fourth of the women are undernourished. And if to think of it, these women will be the future mothers. They will give birth to children. What is going to be the outcome? We need to think. This is the awareness about nutrition which we are talking. And I said initially that I'm happy I have been given this topic to talk about so that we can create an awareness about the situation we are in. So this problem exists. On the other hand, what we are noticing, as the age of the women is increasing, overnutrition, overweight increases with the age of women. If you look at women from 30 to 49 years of age, look at the levels. Almost 35%, one third of the women, they are moving on to being obese. So we have one, undernutrition as a public health problem. Now, with those resources, we now also have to deal with overnutrition in the same population. So where are we heading? Let us go further. Anemia trends among children. We talked about micronutrient deficiencies. We talked about intake of iron, not even meeting 60% of the recommendations. and it is reflected in the anemia trends. I have tried to give you for the last decade and till 2016. On the left, the blue and gray bars, this is the magnitude of anemia among children. Mild degree of malnutrition, moderate degree, or severe degree based on the hemoglobin levels. If the hemoglobin levels are under 8, this is severe anemia. So, if you look at them, what do we notice? For 2015-16, even there, the mild anemias are going high in the population among children. We are talking about the critical years of life. And what are we seeing? Almost one fourth or one third of our children are anemic, even suffering, are suffering from some form uh, of moderate anemia, another one third from mild anemia. So, what is the picture among children? The right hand, the pink and the red bars. Yes, there has been an improvement in the rates of anemia. They have come down. But look at the figures starting for children 6 to 23 months. Just a decade back, about 80% children were reported as anemia. Today, it has come down, and still about 66 to 63% children still are reporting anemia. And for all children under 6 years of age, the figure is still very high. So, anemia reduction is moderate and it remains a very severe public health problem in our country. Anemia tops the list for public health. Here I am giving the anemia figures for women for the last 4 decades. Non-pregnant, non-lactating women, which is the light pink or the pink bars, going on to pregnancy and lactation for the last 3 decades. Look at the figures, particularly for pregnant and lactating women, the yellow and the purple bars. No difference in the last 3 decades. Almost 60% of pregnant lactating women till date are anemic in our country. So, a mother who is undernourished, who does not get enough food, energy intakes are low, who is anemic, does not get enough iron, what is going to be the outcome? The infant, before that, the fetus will have very little chance of surviving. Even if he survives, will be born with low birth weight. This is the picture emerging over the last decade. So, what is happening? Anemia begins early in childhood. The child is born with anemia, and then the conditions go on worsening as the child goes on to be a preschool, adolescent, particularly the girl child who is deprived. The condition aggravates in pregnancy. As you have seen, her intake does not increase, whereas the requirements are high, but her intake is similar almost to what she was having before pregnancy. So, what is the outcome? She will deliver an infant with low birth weight, a child less than 2.5 kgs. But if you look at the statistics, it shows that during pregnancy, if we give iron supplement, folic acid supplement, we can improve the iron status and improve the birth weight of the child. So the intervention can be done, but the awareness needs to be there that we need to be able to look at this aspect. Anemia is a major public health problem for our children. I have talked about low birth weight. Just about 2 decades back, 30% of the children were born low birth weight, one third of our children. The situation is improving. In last decade, 20.4%. Today, 2015-16 data shows 16.4%. Or in fact, 20.4 was for 15-16. Recent data shows it has come down. So the prevalence of low birth weight remains high, particularly in the girl child whose mother were adolescent and stunted. So a girl child who is born, you would notice if she or the child who is born to an adolescent mother, and that girl, as you have seen, about 30% of the adolescent girls are stunted in our country. Chronic deprivation of food. She will give birth to a low birth weight child. So, what are the nutrition challenges? What is the picture? One in every two women is anemic in our country. One in every three children is stunted. One in every three children is malnourished. One in every five children is wasted. 37 of 1,000 babies do not live till the age of 1 year, and mothers who are undernourished, they at the time of childbirth, because of the poor nutritional status, anemia, they have high maternal mortality rate. 167 maternal deaths per 1 lakh live birth. This is the statistics. This is the nutrition challenge we face in our country today. So, what is the picture which has emerged for all of us? An intergenerational cycle of undernutrition is being perpetuated. It is not about a single age group. How does it start? Let us start from the left. A child who is born low birth weight. We have seen 16% children are born low birth weight. What happens to this child? This child who is born low birth weight will be prone to infections. First of all, will have very little chance of survival. If he or she survives, will be prone to infection, will be subjected to growth failure, will be undernourished, will be born anemic. Now, such a child, when this child grows up from being a toddler, from the first, second life onto the preschool age, what the same, this child will have inadequate child care, inadequate nurturing, learning opportunities will be limited, and then growth failure. Repeated infections will further deteriorate the condition. And this child, somehow, with very minimum needs, will go on to be a adolescent, particularly the girl child. Here, she will be undernourished, anemic, because she has started life as a low birth weight baby. By adolescent, her condition, her nutritional status, you have seen 30% children are adolescent girls are stunted, indicating chronic starting from childhood she has been undernourished. Inadequate health care, then girl women health is never a priority. She will be given the last chance to be able to stay fit. Nutritional support, there will be cultural barriers, social barriers. She will be fed the last in the house. And such barriers will lead to further aggravating or undernourishment. And she will be even derived the right to be a child because she will be married early in life. By 18 years, I will show you the statistics. What is the percentage of girls in our country who are already married off? Now, this child, adolescent, will not even have right over her body, and She will then land up with early child bearing. By the time she becomes an adult, she grows up to be a stunted adult, small adult with weight less than 40-45 kg, with height less than 145 centimeters. She is a perfect risk factor to now give birth to a low birth weight baby. So, this is the intergenerational cycle of undernutrition, which perpetuates repeatedly in our country. And we need to break this cycle. Where we start, where we end, that is the most defining thing which we must understand. So, I hope I have given a true picture for what is the food nutrition security in our country.
Absolutely.
Okay.
Absolutely.
My, my last bit is going to be not all is lost. It is not that we are not putting in the efforts. The government's commitment to tackle undernutrition is uppermost, particularly now in the last few years. Lot of commitment has been there. We started off by a national nutrition policy way back in 1993 with the Department of Women and Child Development. They was provided and adopted by the Government of India. And the strategy of the National Nutrition Policy was a multi-sectoral and involved different ministries. And the main objective was to eradicate malnutrition and achieve nutrition for all. And the target in 1993 was set for 2000, year 2000. What was the aim? The aim was to draw attention to the urgent need to reduce malnutrition. At that point of time, 8.7% children were severely malnourished, 43.8 were moderately. So the figures, it was said that if we can reduce malnutrition in the country by half, meaning from 43 come down to 20, severe come down to 4. I have just presented you the data for 2015-16. Are we any near to the target which was set or which was set for the country? No.
Not.
Yes. Then as part of this policy, very ambitious short term strategies, long term strategies for achieving the goals were set. What was that? Quickly, I mean, it is old, but doesn't matter. We need to understand. At that point of time, we realized that children under 6 years are most critical. They need the most help. So, in 93, it was decided expand the net of ICDS, Integrated Child Development Services Program, which was the first program started in the country in 75 to improve the nutrition health status of women, of children under 6 years of age. So in 93, it was thought, let us expand the scope and reach out to almost the entire country. Improve growth monitoring of children under 3 years of age. Reach out to adolescent girls through the ICDS. Why? Because they are the future mothers. Improve their nutritional status, not only nutrition status, improve their skills, lifestyle skills, create an awareness, make them aware citizen in terms of nutrition needs, in terms of health needs. So these were all short-term measures which were there and provide better coverage to pregnant and lactating mothers so that their nutritional state is improved. They didn't stop here. They also talked about fortification of food. We have seen there is lot of inadequacy in the diet. How do we meet it? Can we provide fortified food to selected vulnerable section? So you had iodized salt being provided to all citizens in the country. There was a big initiative to iodize add iron to the salt so that iron deficiency can be looked or it can be taken care of. Sadly, that did not take place. Then there was production and popularizing low cost nutrition foods. So, in a big way, institution like yours, all home science colleges, we were, projects were taken, research was undertaken to be able to come up with indigenous and locally available foods, nutritious foods. Because for a country vast like India, we can't have one food pattern, we can't have one food which will be acceptable for all. So, in regional areas, this was propagated or encouraged. Then major focus was on controlling micronutrient deficiency like iron deficiency, vitamin A deficiency, where supplementation was started, iron supplementation, vitamin A supplementation to children, iron folic acid supplementation for women, pregnant women through the ICDS. These were the measures taken as short term measures. But the long term measure was to ensure food security. How do you ensure? By providing enough food. So, per capita availability of 215 kg of food per person per year was ensured by the government through the PDS, the Public Distribution Service, through the fair price shops. We all know what is the status today. Yes, they have done a good job, but is it reaching the right population? We need to explore, we need to research and find out. Improvement in the dietary pattern, meaning create nutrition and health education, awareness. How? By promoting production and increasing per capita availability of nutritionally rich food. So, food based strategies where horticulture interventions, diet diversification, dietary modification was promoted. Grow more foods which are rich in iron, local available foods which are rich in iron, because green leafy vegetables are the richest sources. All you have to do is to have a kitchen garden. So make food available. These kind of measures were adopted. Then policies for effective cash transfer. Of course, supplementary feeding was there to feed vulnerable group, but also provide cash incentives. Health and family welfare, referral services were introduced, basic nutrition health knowledge with focus on infant feeding practices which were bad, improve those through the ICDS. All these measures were put in place through the National Nutrition Policy. And of course, monitoring, surveillance to see where we are. So the intention was very nice. We have a nutrition policy, but where are we today? As I said, 2000 was the deadline for the improvement. We are beyond and we know what is the status. So, what do we do? The government has taken recent initiatives, many initiatives, and the government is committed and is giving highest priority to combat health and nutrition problems. You have heard Prime Minister Modi ji coming up with in Man Ki Baat, in otherwise talking about nutrition health status of children, improving their status, and he has taken very many initiatives. Niti Aayog has a whole cell which is only working towards the improving the nutritional status. One of the initiatives in 2017 was the Pradhan Mantri Matru Vandana Yojana. So far, we talked about giving food supplements through ICDS. Give the pregnant mother some food. Give children some food. Where the children taking it? We don't know. Yes, some did, some did not. But now they came up with this incentive of cash transfer scheme, providing 5,000 rupees to every woman who reports in an antenatal center who is pregnant. Provide them when they are lactating. Why? This 5,000 cash they wanted to translate in terms of food, the extra food which is given to the pregnant lactating mother. It is very young. The scheme is only 2 3 years old. There are no evaluation study to now tell us where we are. But yes, there are studies going on. We will get the data very soon. But this is a very encouraging cash transfer scheme. Look at Poshan Abhiyan. This is the new National Nutrition Mission, which was started in 2018. And what is the main focus? Is to have intersectoral conversions. So far, we saw what the Ministry of Agriculture is doing. We saw what the Ministry of Supplies was doing. What is the Ministry of IT doing? Everybody was doing their bit. Ministry of Health and Family Welfare. Now it is all coordinated under one head, one decision making to benefit all. Use of technology for real time growth monitoring of children. Where are the children falling? What is why is growth faltering? Do that. Then intensify health and nutrition services. When? During the first 1,000 year of life. The first 1,000 year days, sorry, starts from the time when the child is conceived, not after the child is born. Because if the mother is not well nourished, she will always give birth to a low birth weight baby. And we have seen the intergenerational outcome. So now, first 1,000 days starting from day one when the mother is pregnant. First 9 months, provide the mother good food. Then the next 2 years, take care of the child. And it also talked about a Jan Andolan, meaning involving the community as a whole in bringing
Absolutely.
about a change. And in that context, a Poshan Ma is celebrated. We all know Nutrition Week falls every September. We celebrate Nutrition Week and various activities is being planned. Now from the center, a coordinated effort is made to look at nutrition issues. Celebrate it as a month. We have an International Day of the Child, International Day of Yoga, International Day. Here we have a Poshan Mah. This will help spread the awareness of nutrition related issues, what to do, how to reach out. So, a public movement like we have the Pulse Polio movement at that level, now we will have to take action if we really want to see the outcomes. So, a Jan Andolan is what is required. It's too late, it's too long, we have suffered, no more. Then, other initiatives like increasing the honorarium of field level workers like Anganwadi workers, helpers, so that they are equipped in their job. Then the supplementary nutrition is provided in these programs. Increase the norms, increase the cost because earlier at 3 rupees per day a child was given. Now with inflation, we have to increase the amount and they have gone up to about for children rupees 6, for pregnant women, 7 for undernourished child. More food is required, so rupees 9 per child. So we are talking about increasing the norms, not only, sorry, the payment, the money input for providing food, but also how much to give. So, this supplementary feeding initially would give 300 calories and say 8 to 9 grams of protein. Now, under the new norms, they have changed it. An undernourished child will get about 800 kilocalories plus 20 to 25 grams of protein as part of this supplementary feeding program. So, some food, some snack needs to be given. Pregnant lactating mothers, needs to get 600 kilocalories and 18 to 20 grams of protein per day to meet that additional cost of pregnancy and lactation. So these are the newer initiatives. How do we measure? Just giving the initiative is not enough. How do we measure? What is our target? Outcome of National Nutrition Mission. The current status, underweight children, we have seen NFHS 4 data, 35.7 children. By 2022, our target is to get it down to 20%. This
Huge.
is the target. Huge. That is what, under the National Nutrition Policy in 93 to 2000, we had set our targets. All went waste. Nothing could be achieved to the levels we had kept. Similarly, now is the targets are given, but the government is taking stern actions. Prevalence of anemia among children, 58.4% current status. They want to bring it down to 19.5. Now you can imagine the magnitude of the
Absolutely.
problem plus what efforts have to be put to meet these targets. Among women and girls, reduce it 53% to 17. So, what are we talking about? Here is the National Nutrition Mission target set. Low birth weight, they say, 2% point reduction in prevalence annually from 2017 to 2022. We are at 16.4%. They want 2% reduction each year to bring it down even low. Stunting prevalence. They want, we have seen among adolescent, it is about 34-35% in rural areas. Bring it down to 25%. 2% reduction in underweight annually. Anemia, 3% reduction. See, it is not something we can do overnight, but small steps we need to take to reach these targets. So I hope I have been able to present the true picture. Well, it's not all bad. I think we, a population, such a large population, each one of us, and particularly where our students are today at the Gandhi Rural Institute, with your nutrition background, I think we put in more inputs in creating awareness, advocacy, research into these aspects so that we actually build a very healthy India. So it is our duty. It is for everybody. I think introducing a nutrition paper at the undergraduate level for all students to go through it will be a good start. Like the CBSE has already started a paper on nutrition in class 11th and 12th. Earlier, they taught it as home science. Now, purely nutrition and dietetics is being taught. The skill mission, Skill India, there they are starting new programs to have diet attendance. That level we have to reach out so that we create good awareness. So I stop here. I hope you found my lecture interesting and I look forward to any feedback, questions,
Yeah,
whatever the group would want to.
there are questions. There are questions.
Yeah. All
Professor,
right.
I honestly put my comments like that. Okay, if I had an opportunity to come and sit in your classes, I would have been good. I would have improved a lot as a
Well,
lecturer. As a lecturer, really, it was very useful.
yeah.
Very wonderful presentation, Professor.
Yeah.
Mm,
Thank you.
the coverage what you have given is very deep in terms of the subject, what is expected from you, and what you have delivered. So absolutely, you have covered all the things. Thank you so much, Professor. It was really very interesting.
Welcome.
Now, yes, we need to go to the question answer session. There are many people who are sitting and they're asking questions. In that. Let me come up with the first question, Professor.
Yeah.
Uh, you have touched the subject of increase of money in terms of giving it to the mothers
Cash
before
transfer.
funds transfer before right from the mother conceives till uh, 2 years of baby's growth. So,
That's right. That's right.
what kind of impact it can bring in uh, with rural mothers and children?
See, what is heartening and good thing about this cash transfer is a direct cash transfer in the account of the mother. It is not being given to the family. It is in the account. So the mother will be in charge of using that money. So
Absolutely.
it is Aadhaar linked. The mother has to have an Aadhaar, she has to have an account, and it will go in her account. It is challenging. I mean, an Indian mother will always think of feeding her children first, then herself. But equipping her to be economically independent,
Yes.
that was the idea, to be able to give a direct cash transfer to her account. So, like I said, it is early days. I was involved in a project in Jharkhand where a whole project has been taken up to study the impact of this cash transfer. And I was helping them in that project to see the impact in terms of how equipped the mother is. Because just giving the money is not sufficient. She should know, she has to have an awareness what to eat. Because she thought having just one chapati a day is enough to meet her needs. But what to eat? What is nutritious food? What is the requirement? So, in that project, we were trying out different options to see that cash transfer alone or with nutrition health education, can it bring about a change in her eating behavior? So, those were the aspects we need to understand when we are talking about cash transfer. Look at this present situation. We find ourselves in COVID. No job, no employment. What do we do? So, if we can provide this cash incentive, this can go a long way, I feel. But yes, studies will tell what was the outcome, what was the impact.
True, Professor. Now, I just take a cue from you, and the second question comes, it is very close to what we have discussed now, what you have told now. Those days, I'm talking about 20 years or 30 years back. I'm from a rural area where Dandegam University. I have seen in the surroundings the lower income or lowest income middle class family. They were using very different food habits, and the people those who can afford has a different food habits, like consumption of bajra,
Yes,
that is pearl millet.
all well.
Then
Yes.
mandika, or in nachani, what we call it in finger
Yeah,
millet. Then
yeah,
jowar or jawari,
yeah,
the maize
yeah.
and all. These were all
Yes,
very, very good supplementary.
yes,
Today, over a period of time, the food habit has changed, and now everyone is falling behind the rice or wheat. We are slightly forgetting those things which were actually there, and the physical exercise of mothers.
yes, yes.
How do you see that how we can go back to our golden days?
Yes.
How this kind of awareness can be brought in?
Yes, I agree with you 100%. You see, not everything is bad in our cultural practices. Our traditional practices were very good. Like you talked about eating millets. Why? Because they were locally grown and they were very nutritious. Then practices like cooking food in iron vessels, then practices like using traditional foods, drumsticks being used in cooking today, all those are being lost because we thought that was old, that was not healthy, and we got influenced by what we saw the rich or the urban people or those who could afford to are doing. That is why, if you notice, even in the National Nutrition Policy way back in 1993, one of the short term measure was to promote locally available traditional foods because we recognize the importance of these traditional foods. You know, in our diets, uh, most vegetarian diets, they lack in protein, particularly the good quality protein, because we say animal protein is better utilized as compared to vegetable protein. But if you look at any diet in our country, we always combine cereal and pulses together. It is sambar rice, dal, roti, rice with some pulse. So, mutual supplementation of foods which will improve the amino acid content and improve the protein. These were practiced way back. So, the need of the hour is to identify these traditional practices which you are talking and supplement them with what was going wrong, improve those. So, drive, that is why I said what we need is advocacy. What we need is the change agent, where your students, students of nutrition, students who are working or who have a stake in the welfare of the masses, we need to bring about this communication, education, information. Like we say, behavior change. Today, that is why we don't call it nutrition education, communication, behavior change. Because changing behavior is the most difficult. You can give them knowledge, but you can't make them change what they are doing. So, advocacy. It's a long term measure. We will not find a change overnight, but this is what will only work. So, yes, I agree with you. We need to promote these traditional practices.
Absolutely. Absolutely. Professor, it was very interesting. While I was talking to you, I just recall I used to extensively travel in the country,
Yeah.
almost in all the districts of the states. You can say I have covered. One thing which was interesting, what I have seen is in Indore, for almost 7 to 9 years period in Indore city, these junk food people couldn't get entry.
Very good.
Poha was the main, and even today,
Yeah. Yeah.
that's our own mindset that they say it's not required. Anyway,
Yes. Yes.
thank you so much for the fantastic
Yeah.
thing what you have suggested. So now we are going to the third question. Once upon a time, I'm talking about Tamil Nadu when I was in childhood days. Um, uh, if the tallest leader in Tamil Nadu, Kamarajji, who was then chief minister, wished that the student uh, child should come to school for learning. So he introduced midday meals. Over a period
Yeah.
of time, we took a different thing. Dr. M.G. Ramachandran, who was then chief minister, he felt that the nutrition should be added and it should add value. And later, Madam Jayalalitha ji, she added egg
Yes.
to the midday meal. The government is promoting a lot of, doing a lot of things. How do you
Yeah.
see that this Anganwadi is helping in bringing in good quality of food in
See, we have had this ICDS program now running for the last 4 decades, and you are seeing the kind of problems we are having. See, why was supplementary feeding started? It was called supplementary feeding. Why? It was not as a only food to be given. It was in addition to what the child is eating at home. The gap was of few calories. So if we can fill up that gap by giving them that extra meal in the schools, that is how the midday meal was started. And yes, the best midday meal practices are in Tamil Nadu. So much has been done during Jayalalitha ji's time. Yes, even today. Today, I think Telangana, it was in the news that he has a very robust system of
yes,
midday meal program.
absolutely,
In Delhi, we are doing very well. The
absolutely,
whole education system Even the midday meal is totally being revamped. You see, we are identifying the gaps. What is the gap? The gap between the energy need. The three diets I told you, we need to have that healthy diet. We are not even at the energy deficient diet stage.
True.
We need to include calories from the staple, whether it is the bajra, whether it is the jawar, if it is a wheat staple area, wheat, and supplement it with the micronutrients. This is what we need to do, and that is what the midday meal program. Of course, there are shortcomings, there are pilferages, there are food safety problems which are being encountered. A big role is being played by Food Safety Standard of India. They are training all level of workers. Just recently, we got a call that if we could train Anganwadi workers, can we train helpers? Can we train ASHA workers and others in food safety and hygiene, particularly in the context of midday meal? So these initiatives, I think, will go a long way in providing. Of course, the government is giving the logistics, is giving the economic resources, but each and every one of us need to be responsible to bring about this change. Who is being affected? Our children.
True.
Till we don't take it in our hands, we will not be able to bring about that change. That is why the Nutrition Mission National is talking about Jan Andolan. We can't leave it to the government to do it alone. We need to as a group. You see, South America, their anemia figures were as high as ours just a decade back. They started food fortification in a big way. The baby foods were fortified, sugar was fortified, and they have now got it down to such low levels. So we have to think out of the box kind of solutions. We have to think how and what we can do. And public private partnerships have to come up where money making should not be the objective, but welfare of the people
Should be the
is most important. Only then we can bring about the change.
great, great question. Now, as a layman, I have a personal question.
Yeah,
Professor.
yeah.
How can the differences be calculated among the women and the young children? That deficiencies. How can we calculate it, Professor?
Sorry, how can
Any
we calculate
calculate
the?
the deficiencies among
Oh,
the
acha. All right. See, it is a simple thing. The ICMR, the Indian Council of Medical Research, is the body which gives you references, what we call as the recommended dietary allowances. They have given it for all age, all physical activity level, all physiological conditions, right from birth till old age. The recommendations have been provided. More recently, in 2018, we have come up with the latest recommendations. The last recommendation was in 2010. So, how much of calories to take, how much of protein. Not only that, balanced diet. If I have to give a balanced diet to a child, how much of cereal, how much of pulses, how much of green leafy vegetable. All these recommendations are already there. Now, all we need to do is to have data on what the child is eating, what the population is eating, and find the gap. What is the gap? Is it 10%? The percent adequacy, is it meeting only 60%? Is it meeting 80%? Find out these gaps. And that is what we do as nutritionists, as nutrition student. Most of our time goes in trying to calculate and see what is the nutrition adequacy of the diet. So the deficiency in the dietary intake is all there for us to see. But we have to translate that inadequacy in terms of interventions. How can we bring about? So that is why a supplementary feeding program is introduced. that we found the deficiency was, say, 20%, 30%. So fill that up with the supplementary food. Fill it up. If iron deficiency is there, have supplementation. Give all pregnant mothers, give all children iron drops. Can we fortify food? What other strategies? In fact, for these public health problems like anemia, vitamin A, iodine, there are four major interventions which are being: supplementation as a strategy, food-based strategies, horticulture, fortification, diet diversification are included. Then welfare measures. We know anemia can also be caused by hookworm infestation. Can we improve the environment? So it is not just one factor. A multifactorial approach goes into combating the deficiency problems as well. So it's a very interesting, vast area
Thank you,
and
Professor.
efforts required.
Thank you, Professor. Now I have a different, peculiar question.
Okay, please.
How do you see the role of higher education institutions in bringing awareness, or a contribution of higher education institutions
Yeah,
in
yeah,
bringing
yeah,
awareness in the subject of mother and child nutrition?
yeah. See, I can only give you my model, which I have adopted in my institute. See, we are focusing on three levels when it comes to nutrition. The first level is the capacity building of all individuals. So it's a mother, it can be any layperson who is interested in nutrition, it can be a field worker, it can be a social worker, anybody. The first level is a capacity development programs. Initiate those programs which can create awareness. Basically, so we have 6 month certificate programs, starting at a level of people who can read and write. No official degree. If you can read and write and you are 18 years of age, you get admission into this program, a certificate program, which is very robust. Everything you want to know: what is nutrition, what are nutrients, basic things. Why do I need to eat these nutrients? What will iron do in my body? From there, going on to what does iron do? How it is utilized, how it helps in my growth, what will happen if I don't take this, giving them an idea about public health problems and what government is doing, what you can do, and economics of food. I am, say, from low income group. You are from high income group. What is the difference? How can you meet your needs? Talking about how do I meet it with different income groups? What food to select? How so that my needs are met? Then what are the agricultural programs? What is the government doing in horticulture, in animal husbandry? What are they doing in the white revolution, the milk revolution? So, giving them a basic understanding of these, what we call as the economics of food. So, a basic awareness level package, and we have not restricted it in English, Hindi only. We have got it translated in regional languages. Because if we are talking about reaching to every individual with reading, writing skills, we need to make it accessible. Lack of knowledge. So, this is the first level, awareness level program. For welfare, our fees for these programs is so small: 1,200. We started with, I think, 800 or 900. To meet the needs, it has gone up to 1,200. So that anybody, it is the social welfare, the duty of the university or any higher education to have a program of awareness. Similarly, we have a certificate in nutrition and child care. These are the two linked. So we have one certificate of that level. So these are the awareness level program, the first level. Then the second level are the vocational level programs, where what we are doing, we are developing the skills of individuals who want to work with women, with children, either in NGOs, either in government programs. You see, nutrition is a big thing today. We need a large cadre of people who will be able to function as nutrition health educators in the community, who will be able to reach out to the community and give them the services. So for people like them, we had developed a program, a very niche program called the Diploma in Nutrition and Health Education. Just what basic nutrition messages you need to give, and most important, the communication skills. I may know knowledge, I may have the knowledge of nutrition, but I don't know how to give. So when I go to the community, the people are not willing to listen to me. So the first is you should have the knowledge and you should also have the skill to pass on that knowledge. So this develops or gives them the opportunity to develop as community nutrition educators in the community.
That's
Then we
fantastic.
have this level. Then the third is the professional level. We also need to train people for being able to work in the area of nutrition and health at a higher level. So, professional development, train manpower for the market force. Today, we need dietitians, we need nutritionists to be able to function either in hospitals, either in the community, or self service entrepreneurship. Today, many of our girls, they are starting their own dietetic centers. So, a master's program in dietetics is which is very sought after program. So what we are doing, we are catering to four different levels, because the fourth level then becomes research, training. Without research, we will not be able to move on. So for any higher education, you just can't say that I am higher education, oh, I can only do PhDs and masters. You need to start at that level. It is our social responsibility to create awareness, to bring about a change. So, this is the four level which I have done in my university. Like you were saying, I had the privilege of setting up my department. You know, when we joined, we were part of women's education, and I had literally had to fight to have a discipline of nutritional sciences, because nutrition is a discipline in itself and the need of the hour. So each one will has to be, you know, have that skill, have that knowledge, have that zeal to be able to move ahead. So this is my take on, you know, what the higher education needs to do.
That's an eye opener for almost everyone who are involved in higher education, in particularly nutrition. Professor, I have last question, which is again,
Okay.
it is from
Yes.
me only, not from others. You
Okay.
are you are very well known as a taskmaster in terms of research. You have touched the
Where did you
subject.
get that? Where did you get that information?
We are also traveling in the parts of Delhi, so this is something which is very unique in you.
Yes.
And
Yes.
I just I really saluting that and appreciating that. I just have something in our we do also have our research department. People are doing research in Gandhigram Rural Institute also in this.
Yes.
What is it that you are expecting from a researcher as a guide? What is it that you are
Yeah.
expecting? Because today I have seen cut paste copy type of researches are done.
Yeah, exactly, exactly. See, Dr. Krishna Kumar, we need to first identify at what level we are talking about. For example, in my diploma program, I have a project work, 8 credit project work. I am not looking for a person to become a hardcore researcher after doing this. What was the purpose? The purpose is what you are learning in theory. In 15 days, go and try it out in the community. You are training to become a nutrition health educator. Okay, so I only want you to take it as a research project where you just experiment with what you have learned in theory. We have learned that, say, diarrhea is a major problem among under 1 year of age. Suppose all I want you to do is plan a proposal where go and see what is the prevalence of diarrhea in any community, go and see what practices mother is following, go and see what is the knowledge of mother, prepare a simple questionnaire, take 25 subjects, and complete a report in 20 pages. That is what I am expecting from them. I am only initiating them,
It is
creating an awareness by learning by doing. That is the concept. But when it comes to my master level students of dietetics, what am I looking for? I am looking for helping them develop a critical thinking in that area. किताब तो पढ़ लिया, you know what is anemia, you know what is what. By master level you are a master.
yes,
But if you cannot apply that knowledge in practical, if you are going to be a dietitian and a mother comes and sits in front of you and tells me or tells you, tell me, is my child undernourished? Like you were asking me, if I can't give a reply to that mother, or she tells me, can you look at my child, just clinical features, and tell me, is he or she healthy? She says, please monitor my child's growth. If you don't know how to use a growth chart, you don't know how to weigh the child, your knowledge is not complete. So you have to be a researcher. You have to do that critical thinking. You have to participate in that process. What is happening today? The students do things just for passing an exam.
absolutely.
They are not taking it as an initiation to the world outside. It is just the beginning. So when you tell me I am a hard taskmaster, this is the problem I face. I tell them, you don't deserve a degree. Forget the exam and research, there is no reference. Only published papers are the reference. Your literature review is the reference. For theory, we provide you books. You can read 100 books and go and give an exam. Selective study कर लीजिए आप. You will still get a 40 marks. But in research, you can't get a 40 marks. You will, if you have done a good job, you will always get an 80. All my students get not less than 80. Why? Because we have made them so thorough. Each and every step, it's learning by doing. And I guess today generation people want it quick. They want a degree. They just want a degree. Learning is not an important aspect. So maybe sometimes I am a hard taskmaster because there are no shortcuts, I tell them. So that is the argument.
It is really very people should understand that when I speak to people or I deliver a lecture to someone, I used to tell, please don't go behind the numbers. You
Yeah.
understand the subject and develop
Yes.
your skills.
Yes.
What you have
Yes.
acquired in terms of knowledge, you
Yeah.
enhance your skill to apply it.
Yeah.
If
Yeah.
these two things can be taken care of, then you are successful.
See, I like you were telling me, it's a marketplace there. There is a need. Today, nutrition counselors, dietitians are in great demand. Even I am giving a degree, you are giving a degree, DU is giving a degree, Baroda is giving a degree, and there is only two positions. Who will get that position? if you deliver in the interview.
Yes,
If
knowledge.
you can, knowledge, and knowledge not of the bookish kind. So that is what you have to work for. Exam, everybody will pass. Nobody is going to fail. But it is a long journey. It's for the longer part, I tell them, work hard, understand, and do it. That will take you long.
It's a beautiful message to
Yeah.
students, particularly the researchers. Now, I know, Professor, it is a very tight situation for you. You are doing multiple things, and time is one thing which is very important.
Yeah.
You have taken your valuable time to come to our webinar, and we have enriched,
Not at all.
rather, our entire student fraternity will watch you. Not only our fraternity, I pray that it should go to even larger public, and people should understand what is the nutritional value and what is the importance of nutritional value in terms of bringing the country into a different level what our Prime Minister is dreaming.
Yeah.
Now let me come for a formal closure, Professor. Dil nahi karta hai. Still, I have to close this session.
Yes.
Mm,
Yes.
I'm really very happy Professor Deeksha Kapur had come to our webinar series, and she had given a very wonderful lecture on the title of Role and Importance of Nutrition and its Awareness among the Rural Mothers and Children in Building New India. I thank you, Professor, for coming with us, and I invite on behalf of the staff, student fraternity, Chancellor, Vice Chancellor, and Registrar to come to Gandhigram once post this Corona scenario, and please do help between our helping in our students' career also.
Certainly.
And
Certainly.
I'm formally closing it. Thank you so much, Professor. Jai
Yeah.
Hind.
Yeah. Thank you. It was my pleasure. It was all my pleasure.
Thank
Thank
you.
you so very
Thank
much.
you, Professor. Jai Hind.
Right.